Well, good afternoon, everybody, and welcome to the University of Edinburgh's webinar on COVID-19. Where are we now and what's next? I'm Jonathan Seckl. I'm the Senior Vice Principal at the University of Edinburgh, and by background, I'm a Professor of Medicine, a hormone doctor. My expertise is in what stress hormones do to the brain. Not really desperately relevant to today's conversation, but I'll do my best. We have an all-star cast today of leading thought leaders from the university who will give brief presentations of their understanding of COVID-19 and what the critical questions and challenges are as we sit here towards the middle of August, now 8 months into an almost unprecedented pandemic, certainly a once in a century event. And that's a fabulous position for the university to be in, because we really have a very large number of extremely high functioning experts in this area. And so it's important that we share. But probably the most important thing is that this session is really about students and staff interacting. It's typical of this university. We're very democratic, very open. And as a student here, you get the opportunity to interact with some spectacular world-leading thought leaders. And this would be a good example of how this will work. It will work like this more and more in the world in which we find ourselves. So I hope that this is an interesting and exciting and exceptional event for students, staff, researchers, and friends around the world alike. And I'm delighted, having said those few words of introduction, to introduce Ellen MacRae, who is president of the University of Edinburgh Students' Association, who will chair our event and take us through the rest of the hour. Ellen.
Thank you, Jonathan, and hello, everyone. I'm really excited to be here today, and thank you to all of our panelists, which you can see on the slide. I don't know if it's beneath me on this webinar. To Jonathan, Linda and Devi for being here today, but also our students. It is, as Jonathan said, a really fantastic opportunity for us to collaborate in an event such as this. So both Devi and Linda will be giving a short presentation on today's topic. So I'll just jump straight in and introduce Professor Lee Sridhar, who is a Professor of Global Health in the Usher Institute at the University of Edinburgh. She chairs the Royal Society of Data Evaluation and Learning for Viral Epidemics Committee. She sits on the Scottish Government COVID-19 Advisory Board and is working with the Director of General WHO to support the WHO response to COVID-19 on policy and governance issues. She has featured on almost every UK broadcast, print and online media outlet in the last few weeks, as well as the international press. Her books include Governing Global Health, Who Runs the World and Why, and The Battle Against Hunger, Choice, Circumstance and the World Bank. She has published in Nature, Science, the New England Journal of Medicine, The Lancet and the British Medical Journal. She served on the board of Save the Children UK and the World Economic Forum Council on the health industry, and co-chaired the Harvard-London School of Hygiene and Tropical Medicine independent panel on the global response to Ebola. So incredibly impressive, and I'm so happy that you can be with us here today, Devi. I will hand over to you.
Perfect. Thank you, Ellen. I'm so delighted to be here today, just to kind of interact with students and get back to core university life. So I wanted to just give a short presentation, 3 slides of where we are with COVID-19 in the world, what we know, what we don't know so far, and then to kind of look ahead at what are countries trying to do with this, what are different governance strategies of dealing with this kind of outbreak, because there's no one answer, there's no simple solution. So if we go to the first slide, I mean, the thing to say is that this outbreak is taking off across the world. Unfortunately, it looks like the worst is ahead of us in terms of number of cases. Every day, new daily records are being set. And this is just for those who are actually confirmed cases. And for all those that are confirmed, we have to remember all those tests, that is reliant on having a test to confirm it. So there are many places where there are probably more cases than we are finding through testing. And just to say that if you look at this, it started off in Asia, and you can see that Asia, largely China, South Korea, Taiwan, Singapore, Hong Kong, kept good control of it. And then you could see it started taking off first across Europe. These were the cases around Italy and Spain and France, Britain. Then you got the States coming in. This is the Americas, and you can see the States still being an important contributor. And then Africa coming in quite late. So just to remark as well, this, having worked on infectious disease control in the past, this kind of went against what we had thought, where we had thought an outbreak would emerge, probably in quite a rural place, a poor country, unconnected country, and then spread from there, where this was a virus that emerged in more of a kind of rich country context and spread through rich countries first, and is now hitting developing countries. And we're seeing the devastation in Latin America, Sub-Saharan Africa, as well as in South Asia. And also how it spread was through elite networks, cruise ships, business class travelers, ski holidays, ski resorts. This was just not what you would have, let's say, predicted, or that the UK and the US, which were consistently ranked, first and second for pandemic preparedness, would be struggling and still struggling. It just shows the extent of the challenge. I think no country has found it easy to go through this. So go to the next slide. What we have learned so far. I just wanted to go through some of the big issues, because part of the problem with advising governments and governments taking scientific advice is the uncertainty. There's so much uncertainty over what we know, what we don't know. But over time, we've learned more and more. If I think from early January, when we had this unknown cluster from, detected in Wuhan of, a couple dozen patients, no one really fully understood it, to kind of all that we've learned since then. And just try to summarize here some of the big issues. So the first on immunity, what we know is we now have a pretty reliable antibody test. And we know from seroprevalence studies that's looking at how many people have antibodies through kind of random surveillance in a population, that in most places, let's say across Europe, it's under 10%. Cities are a bit higher, maybe closer to 20%. But if we look at like southwest of England, around 3%, Scotland, around 4 to 5%. So you aren't seeing huge exposure through antibody tests. Personally, I found that quite disappointing. If we had come out with much higher results, that would have been more positive, because then you thought we're further along in terms of immunity development, but antibody tests have not shown that. But then we also have this emerging focus on T-cell response. I'm not an immunologist, but what immunologists tell me is that T-cell response means that you could have an immune response even if you don't have antibodies detected. And that would be quite good, because what we don't know is how long immunity lasts. It seems like it's probably 3 months, possibly longer, and the extent of population immunity. So if we actually had a reliable T-cell test in terms of exposure, would it reveal many more people? Then turning to health issues, we have learned this is not a respiratory disease. This is actually a multi-system disease. Doctors say that it affects the heart, the lungs, the kidneys, the blood vessels, and this has helped them clinically, I think, treat patients better, because they've learned actually how to cope with all the different ways it affects people. And we've also learned about something called long haulers, which is that when you recover, it's not like you just recover and you're fine. Actually, you could have long-lasting health issues. I know Professor Devi Bogart at the University of Edinburgh has written on this. And her experience of having COVID and dealing with this over a longer time frame, as well as, initially you thought kids were not affected. And now we've learned there is this pediatric multi-system inflammatory disorder where kids seem to have a delayed reaction. But again, the numbers seem quite low. So what we don't know is how long recovery could take. So the people experiencing this long hauler condition, longer term recovery, could this be gone in months? Is it going to take years? And the exact percentage of people who develop these long-term health issues, it's been estimated 5 to 10%, but we don't really know. And same with kids, it's estimated to be rare. We just don't know how rare. The third is on a vaccine. There's several promising candidates in phase 3, pretty remarkable, never seen it this quickly. We don't know is whether one will actually provide protection from reinfection and for how long. And that's what we're hoping phase 3 trials might show. But I think this is quite hopeful. We've never had vaccines develop this quickly, from actually detecting a pathogen, getting the sequencing, to actually getting it into people and having people, injected with this vaccine. treatments. We have 2 approved treatments already for those who are hospitalized, one reducing the chance of death, one reducing the length of stay in hospital, but we don't yet have a treatment, which would really what we need to keep people out of hospital and the burden off health services. That would be the game changer here, because the health services crunch is what's an issue, which I think Linda will talk about. And finally, children are a real puzzle. We've learned younger children are different to older children. Both can carry the virus, both transmit to different extents. Younger children seem less affected. You've had less outbreaks, let's say in primary schools, less children affected. Older children seem to be very biologically similar to adults, but we still don't know why children are less affected. I mean, I've heard all kinds of hypotheses, including that children are just shorter, and so they infect less other people. We also don't fully understand the role of outbreaks in schools and community transmission. You've seen, again, it's gotten quite politicized around schools, but I think we don't fully understand how they might affect community transmission. And we've seen schools play an important role, like in Israel and Australia, in spreading outbreaks. And we've had other places like Germany and Denmark where schools haven't seemed to make much a difference. Go to my final slide. And this is future scenarios for countries, and all have trade-offs. I think that's the key message, is we will not have our pre-COVID life back. And the governments who are trying to have it all are taking trade-offs. They're just maybe not aware of them. So the first kind of strategy you've seen countries take is perhaps the most harsh, which is effective elimination, what we can call the New Zealand or the Ireland model. You just try to get rid of it. You lock down hard, you chase the virus with big testing, you trace it, you have strict border measures, and you just keep trying to stop imported cases. It's not easy, as we've seen from New Zealand. This is a very tricky virus to stop, but you just keep trying to get rid of it, and you go into a hard lockdown again if you see cases, and just try to get rid of it and get on with your life. The second is control. This is the German or South Korea model, where you have a voluntary or a light lockdown. You support this with strong testing and tracing. So, people change their behavior to hopefully have more distancing. That's a kind of a new normal, but you support it through testing and tracing, and you have strict rules over super spreading events. This means events where a lot of people become infected at once. Most people don't infect others. I think it's about 4/5 of people don't infect anyone else. It's the 1/5 you want to catch, because it's like one person walking into a club in Spain and infecting 91 others. These are the kind of super spreading events. And then testing and tracing breaks down, because you just can't chase fast enough that chain of infections. And so you might need another local lockdown, and light border checks. So you keep some kind of check on your borders, and they're testing at Germany and South Korea are testing at airports. And finally, you have what we could maybe call the herd immunity approach, or the buildup of natural immunity, which is what Sweden, I guess, has become the paradigm of, which you try to slow it running through your population. You hope for some kind of mutation, which makes it less adverse in terms of its health impacts, or some kind of treatment to treat those who come through. You try to keep your deaths and your disability to a minimum. You try to ensure your health services don't collapse in the meantime, because if you have a spike in the number of people who need care, that means very harsh triage decisions. And you try to keep confidence in the economy. And I think what comes out clear in all 3 of these is your economy takes a hit. There's no way to get through this without your economy taking a hit. Sweden has taken a similar hit to its Scandinavian neighbors, and that's because of the confidence that people change their behavior, and they're also interlinked economies across the world. So you can't just hope you get through it. Probably the place that we'll talk about, I guess, hopefully later, but the place that has actually seen quite well, has done well, is actually Taiwan, and we can talk a bit about why that is. But I'll stop there and hand over now to Linda, who I think is going to continue on the effects of COVID-19.
I'll quickly jump in and introduce Linda first. Thank you very much, Devi. So Professor Linda Bauld is the Bruce and John Usher Chair in Public Health in the Usher Institute at the University of Edinburgh. Linda is a behavioural scientist with a PhD in social policy, whose research focuses on 2 main areas: the evaluation of complex public health interventions and how research can inform public health policy. Since 2014, she has combined her academic role with a secondment to Cancer Research UK, where she holds the CRUK BUPA Chair in Behavioural Research for Cancer Prevention. Linda is a former scientific advisor to the UK government on tobacco control and current advisor to Health Canada and the World Health Organization FCTC's Secretariat. She is a Fellow of the Royal College of Physicians of Edinburgh, the Royal Society of Edinburgh, the Academy of Social Sciences, and the UK Faculty of Public Health. During the COVID-19 crisis, she has served as a member of the COVID-19 Rapid Response Funding Panel for the Economic and Social Research Council. also coordinate these Usher Institute's COVID-19 webinar series and has regularly appeared in print and broadcast media to discuss the key developments during the pandemic and the measures taken to address COVID-19. So thank you also, Linda, for being here today, and I will hand over to you.
Thank you very much, Ellen. And like Debbie, I'm really looking forward to getting back into teaching. So it's great to have a chance to discuss these important issues with our students and prospective students today. So first slide, Susan. So I'm just going to emphasize some of the, so if you go, there we go, some of the aspects that I've been most interested in during this pandemic, and they are fundamentally, I guess, fall into two areas: how humans are responding to the crisis and government action, and then also how the state responds. So what is government action, and what are the unintended consequences of the constraints that many countries are facing? And then looking ahead, how might we be living in the future? We can be more certain about the short term, but we have big questions about how it will affect all aspects of daily life in the future. So the first thing is, how has our behavior changed? Now, bearing in mind that there are 188 countries around the world that have introduced some form of measures to deal with COVID-19, and in most countries, those have affected human behavior in really very fundamental ways. Now, of course, we've encountered many changes in the past, global conflict, regional conflict, economic crises, etc. But what is distinctive about this pandemic is the scale at which it's happening. So a behavioral change has been required. And I think in the UK, across Europe, and high-income countries were particularly conscious of things like physical distancing, the hygiene expectations, quarantine, which is a big source of debate, travel restrictions, home working, face coverings, and then avoiding crowded places. But in behavioral science, we often use a framework called COM-B, which is capability, opportunity, and motivation. And that means that populations around the world don't always have an opportunity to respond to government guidelines because they can't. They have to go out to maintain a livelihood for their family. They live in communities where distancing isn't possible. They don't have adequate resources necessarily to be able to proceed that way. And that's why you see such a different pattern around the world. And then even within the UK, the data tells us that the ability or willingness to comply really varies in relation to, for example, women generally being more willing to comply than some men. Again, your opportunity, how many resources you have in your household, and also thinking about people's age. So we see that in some instances, younger people, particularly those who've been more disadvantaged, don't believe the messages they're receiving from government or want to engage with them. And it's also influenced by things that we know very well from the literature, the availability of information, the resources that are available to implement those changes, and crucially, trust in governments and leaders. And even within the UK, we've seen divergence in terms of the polling, the extent to which people trust the information they're receiving and therefore are willing to engage with it. And then crucially, what is happening in your local community? So if you're living in a crowded community with few resources, that may be different to how if you have good housing, lots of space, can comfortably work from home, etc. And then the other thing I would emphasize is there continues to be a debate or uncertainty about the evidence underpinning key measures. And I think even within university environments, experts don't always agree, and the advice, as Devi says, that governments get can vary. It's a new virus. We look for evidence everywhere. And even though research has expanded at scale, we don't have all the answers. And then importantly, there are vested interests that want things to go a particular way for the economy or their sector of the economy. And they tend to influence public debate. And all of you will know there's often misinformation that is spread, particularly through digital media, that can affect how we respond. And that will be important, for example, as we move forward and talk about vaccination and how willing people are to comply or take that up. Next slide, Susan. So there have been a range of what I would call, and most of us studying this, to call unintended consequences of measures that have been introduced to deal with COVID-19. So the first one, and I can't emphasize this enough, is the disruption to education. More than 1 billion young people out of school in recent months, not having face-to-face teaching, and just really incredibly entrenched inequality. So those who've had to learn from home are only able to do so if they have the resources, the attention and support of parents. We've seen even in the UK big differences between groups who've been able to do that or not. And then the duration with which children are out of school, we know from previous studies, even a short period out of education, formal education, can have an impact for years to come. And of course, in the university sector, we're all trying at speed to prepare to welcome our new students and give the best quality experience that we can, but facing challenges through the pandemic. Secondly, and an area that I do a lot of work in with CRUK and others, of course, there's been a big indirect impact on morbidity and mortality. So just thinking about cancer care in particular, we had to pause all our cancer screening programs for breast, bowel and cervical cancer in the UK and elsewhere. And we know that late diagnosis, which can often come from initial screening or identification of a cancer, the longer somebody has to wait, the poorer the outcomes are. We've seen a big drop in accident and emergency admissions, a big drop in referrals from primary care, and all of these things are a backlog which is being stored up, and we know that will have a direct impact on outcomes in the future. We also know that mental health has been a huge issue as we've had to face the constraints of lockdown and other public health measures. And then finally, the economic consequences look as if they will be severe. So even in the UK, GDP fell by over 20% over the last quarter. It looks like we are one of the worst hit of all the G7 nations. And just to put that in context, for the EU, the Eurozone overall, that was just 12.1%. But most countries, even those that have not locked down in a significant way, are having economic consequences because, of course, we live in a global economy. And just to emphasize, unemployment, inequality, poverty, all has health impacts, mental and physical health. Next slide. This is my final few words. So what do we do when we look ahead? How might we live in the future? So this is unknown, but what we do know is this virus is here to stay, and we have to learn to live with it, to mitigate it, and to treat it. And of course, at the University of Edinburgh and across the academic community, many colleagues are doing important research to look at new treatments and also vaccines, and just thinking about how we can cope with that in the future. Things we can do ourselves: hand and respiratory hygiene, physical distancing, protecting hospitals and care homes must continue. I think we're going to move on to talk about that. But certainly this distance we need to maintain from other people, which is not normal to us, I think will continue until we get cases down to zero or a very low level, and we're some distance off from that in almost all countries. We're all embracing technology, or trying to, but that is dependent on resources, but it's caused huge changes, and that will be essential in the months to come. Travel and mass gatherings are likely to be restricted for some time. That has implications for all sectors. And ideally, we would be cooperating globally to find solutions to this crisis, but the evidence of that is limited. Nationalism has been an issue, countries' protectionism hasn't been great, and our support for key intergovernmental organizations has varied. And then finally, we need to prepare for future epidemics, and research capacity and infrastructure will continue to be key. And I just wanted to conclude by pointing to just a UK poll here on this slide that shows you that most people believe that if we have further negative outcomes, future significant spikes in COVID-19 in the UK, that actually people will be to blame, not the government. And I would question that, but it does mean that many people have internalized this message that it's all about individual behavior. And I think behavioral scientists would be amongst the first to argue that it is not as simple as that. Thank you.
Thank you very much, Linda. I'll also invite both Linda and Devi to appear back on screen as we move towards our questions submitted by our students. I'd like to thank every student who submitted their questions. We've had questions from both current students and prospective students, so it's really excellent that we've had that engagement. But we'll start off with Cameron, who is a medical informatics PhD student who has a question initially for Linda Bauld.
Great, thank you very much. With a densely packed elderly population, no national lockdown, and strikingly low levels of testing, why has Japan done so much better in terms of the number of cases and deaths compared to other similarly populous and prosperous nations?
Thank you, Cameron. Well, I'll start and then hand over to Devi. So I think it is really important that we do these cross-country comparisons. Devi already highlighted examples of different countries with their approaches. So Japan is an interesting case. In terms of the numbers of cases they've had that have been identified through formal testing, I was just looking this morning, just over 55,000, but just over 1,000 deaths. So you're absolutely right, Cameron, that the impact of COVID-19 on that country does look to be less, but not the lowest in the region, I would emphasize, in terms of Southeast Asia. However, Japan's cases are now rising. Their numbers are actually very similar to the UK. They had over 900 a day or so ago, and we were about 1,000. But in terms of why there might be some differences, you're spot on that in terms of their demographics, and older, in fact, the world's oldest population, and we know older people are at risk, you would assume that the outcomes could have been worse. So researchers have speculated on what some of the explanations for that might be. And some of the theories are that it's a country that is more comfortable with increased physical and social distancing. Crucially, and I think this is important, that for many, many years, they've been very comfortable wearing face coverings, particularly in influenza season, but just generally, it's something that Japan does very well as a country. They also have a very well established public health infrastructure from the 1950s, setting up their track and trace for other infectious diseases, particularly TB actually, where they had a big outbreak in the 1950s, and that has undoubtedly served them well. And the other thing I was doing a bit of looking at in relation to their response, which was of interest to me, is that early on in the pandemic, even though they didn't implement a very strict lockdown in the way that some of their neighbors in the region did, they did launch a public information campaign around the 3 C's, which were avoiding enclosed spaces with poor ventilation, avoiding crowded places with many people, and also avoiding close contact settings, such as face-to-face contacts. So that may be part of it. And then finally, and I think this is relevant, they have the lowest rates of cardiovascular disease and obesity in the world. And we know that those are really important risk factors for COVID-19, specifically in relation to disease severity. So those might be some of the reasons, but I'm sure Devi has other things to say on that.
Thanks, Linda. That was great. I'll just add, because that was a comprehensive answer. One thing that Japan had early on was the experience of the Diamond Princess cruise ship. I don't know if you remember this cruise ship, which was like a living laboratory of these people stuck on a ship. They knew the infection was spreading. No one really knew at the time how exactly it was being spread. They didn't want to take the people off the ship, and it was kind of Japan's responsibility. It was them, sitting in Tokyo to figure out what do we do with this ship. And they learned a lot from that. And most importantly, they learned about asymptomatic carriers, which I think other governments were quite slow to catch on to, which is that people can feel fine and still transmit it to others. And so, as Linda was saying, their early messaging was around that, which is like, act like you have COVID because you could. And so that meant there was widespread mask usage, people avoided crowded spaces. You had behavioral change early on, which looks, if you look on the ground, a lot like lockdown. And we've seen it in the UK, we've lifted lockdown restrictions, but behavior hasn't gone back to what it was pre-COVID. People have changed how they interact with others. The second thing is, and I've been looking at this closely in terms of test, trace, isolate, is they utilized a cluster based approach. As I mentioned, 4 out of 5 people don't transmit the infection to others. So you want to figure out who that 1/5 is and make sure they're not, like, one person isn't transmitting it to 15 others or 30 others, because then your whole system breaks down. So what they did is they backtrace. When someone became infected, they try to figure out, where did that person get that infection from? I think now they're doing it in England and Scotland, but it took us a while to get to this point. And they actually went back and tried to identify these super spreading events and stop them. So if you could stop the super spreading events, you can actually keep your numbers, I think, they're more manageable. Where you see like South Korea breaking down, or even in Scotland with Aberdeen, different cases breaking down, is when you have super spreading events and your testing and tracing can't keep up with the pace at which the virus is spreading. And then you have to have some kind of lockdown measure to basically freeze time. So I think Japan is actually definitely one to watch, as well as the underlying epidemiological profile of the population. Obviously, if your population is healthier, it helps with this kind of virus.
That's grand. Thank you so much. And thank you, Cameron, for your question. We'll move on to our next question from Emily, who is a geography master's student. Thank you, Emily.
Hi, thank you so much for giving your time to speak to us today. So my question is that Older people are more at risk from COVID-19, along with those with underlying health conditions. But how do we keep protecting those groups as we start to open up as a society?
Thank you. I'll pass over to Devi to start off answering that question.
Sure, thanks, Emily. And I'd be curious what Jonathan and Linda have to say. I'll just give my take on it, which is this is a virus that has, which causes COVID-19, which is a multi-system disease. So I don't think that we can just say that you can let a certain percent of the population get it and others can't. Because I mean, the way I'd explain it to younger people, and I consider myself still young, not as young as students, is that it's a bit like Russian, roulette, right? Like imagine you had 100 Smarties and someone said to you, 10 of those will cause you to have longer term health issues. We don't know how long, but for months, but 90 of them are fine. Would you eat one? I don't know. So I think about it this way. I'm not as worried about death with younger people. I think we've seen you're unlikely to die from this if you're young, but we don't fully understand the longer term health issues for younger people in terms of their lungs, their kidneys, their heart, and all the things we're seeing. Even with kids, I think if you have a small percentage of kids affected by this, you're not going to see this rare pediatric disorder. As soon as you see prevalence jump, like we've seen in the States, all of a sudden you're having hundreds of kids showing up in hospital. And we don't want, I know people say, oh, but kids get the flu. I'm like, we don't want kids dying of the flu or getting sick from this. I mean, that's the whole point of public health, to stop it. So I think the overall message should be, we don't want anyone exposed to this. Also coming back to the shielding argument, who exactly would you shield? Age is an easy one, but do you shield everyone who's asthmatic, who has hypertension, who has diabetes? And then on top of that, do you shield everyone who's obese and overweight? How do you determine who's obese and overweight? Do you then shield all men? Because men also are a risk, being male is a risk factor. Do you shield everyone from a deprived background? Oh, ethnicity. So if you're from an Asian or a Black background, so who's left? It's almost like, I don't know, it's going to look like the cast of Love Island at the end, right? It's like, that's all that's left, the healthy early 20-year-olds. And it's very hard also, I'll just end with this, to shield. Schools are the perfect issue. I've done a lot of work on school reopenings. So schools, if we assume secondary schools, kids can mix and transmit it and they're going home to their families, what does it mean for parents? Do they send their kids in and to grandparents? Do they not? They're still part of society. So I think the idea you could just take the 20% who are vulnerable and put them onto an island and say, we let it run through, doesn't understand societies. And it's going to mean really tough choices for teachers and for elderly teachers and how much risk people have to take. And I just think a better approach is just shield everyone instead of just shielding the vulnerable. But I don't know if Linda and Jonathan want to come in if they have a different take on that.
Shall I chip in for a moment? I just want to talk about one sector in particular, Emily. It's a really good question. So 40% of our deaths in Scotland have been in care homes, and we've seen that globally around the world. And unfortunately, the stark reality is that we've systematically underinvested in social care in the UK and many countries. It's absolutely the poor cousin of our system. And I think if anything good will come out of this, and I'm actually not that optimistic, but I retain some optimism. I think we need to look very carefully at those settings and what we do to protect them. Now, the good news is most governments have woken up to this. And I think routine testing of staff in care homes and really almost forming a protective bubble around those settings is going to be absolutely key. And that applies to hospitals as well, actually. We're some way off protecting hospitals, as we should do, from this virus, but we're getting there. So I think those are important elements. And then the final thing I would say from a behavioural perspective is tailoring advice to groups and people understanding their own risk from what we know from the science is crucial, because people can also not eliminate the risk to themselves because they're reliant on others, but they can be more vigilant and expose themselves less. So those are some things I think will be helpful.
So probably as the only person here who comes into the category of elderly, I would say, I think what a lot of my elderly chums say, Emily, which is that give us the facts and we'll make our choices, because the risk is particularly to the elderly, particularly to elderly males, particularly to elderly males who are overweight and come from particular ethnic groups. And unless they have diminished capability to make their own decisions, they probably want to make their own decisions. They want to say, okay, if I do this, I have a risk of catching this illness, but I want to have a life. I may be 70 or 80, but I want to get about and do things. Other people say, no, I'm going to isolate myself. I want to give myself the best chance of getting a telegram from the Queen and I'm going to stay isolated and away from all these dangerous young people. There aren't many people who say that, by the way. Most of us want to see our kids, grandkids, great-grandkids, friends, relations, and do things and recognize we're taking a certain amount of risk. But of course, all of this then asks very big research questions like, what is it about the elderly that makes them most vulnerable? Is it the decreased reserve of the multiple organs that are impacted by this illness? Simply an old pair of lungs have so much less to give before they fail completely. An old kidney, an old heart, an old brain. What about the immune response? We keep hearing that people are getting really sick because of their autoimmune reaction, their cytokine storm, which is killing them. Of course, as you get older, your immune responses get weaker. That's why vaccination is less and less effective as you get older and older. So there's something else in there, isn't there? There's something missing in our understandings. We've got some really interesting research to do as well. But I have a horror as an old doctor of the state telling people the decisions they must make for things where it isn't unreasonable that they make their own decisions. And I think this is one of them. People will have to balance risk against benefit for themselves.
That's a very good point. Thank you for all of those comments. I think that's a really interesting point to be made about not only the research questions for understanding this pandemic, but also understanding society and how we work as well. So thank you, Emily, for your question. We'll move next on to our third student here today, Ruoyu, who is a geography PhD student. Thank you.
Thanks for your presentation. And my question is that the COVID-19 has influence on people's outdoor activities and may encourage sedentary behaviors. So will this exacerbate the inequalities for the non-communicable diseases, such as the obesity during and after this epidemic? So what do you think the long-term effect of this will be, and how can we address it? Thank you.
That's a really good question. Thanks. I think it was for me first. Is that right, Helen? Yeah. So just to emphasize that non-communicable diseases still, unfortunately, result in premature mortality for many more people in the world than do infectious diseases still. And I think that the links between what we've all experienced during the crisis and the risks of those conditions like cancer, cardiovascular disease, diabetes, etc., are real, but they're probably temporary. So just focusing on exercise at the moment, lockdown measures did constrain people's ability to exercise, particularly in countries like Spain, for example, where for a period you weren't even allowed to go outdoors. It was very, very harsh lockdown. That didn't occur in the UK. But you can see from the survey data, I was just looking from some of the research that's been funded by the Economic and Social Research Council, actually. 2/3 of adults during lockdown in the UK thought exercise was even more important during the current crisis, but it wasn't equal in terms of their ability to be able to take advantage of the freedom that they had to go outdoors and access exercise when gyms and other settings were closed. So people from higher socioeconomic groups were much more likely to have done more activity in the past week. It varied from around 40% of higher income groups compared to 25% of those that had fewer resources in their household. And also people who were living in rural areas in general were more active than those in urban areas. So I think your point about inequalities is an important one. When we also look at what people were consuming during the pandemic in terms of dietary patterns, there is again a divergence of some people eating more of the foods that are not necessarily beneficial to us, and others actually improving their diet, particularly those with more resources. We all saw the videos of people making sourdough and sharing recipes for those who, again, I emphasize, have resources in the household to do so. So I think these changes are probably temporary. I'm actually quite optimistic that there will not be a long-term impact on physical activity at the population level. But there's no doubt, coming back to the shielding discussion, that for groups who have to, are more restricted in the opportunities they can access, it may have an impact. And we certainly did see a gain from some of the survey data for older people, those who were more isolated, even lower levels of activity that they were doing before they weren't able to engage in. So these questions are all being researched. I think we'll see more that comes out in the future, but I'm relatively optimistic on the behavioral side that hopefully their constraints on physical activity are not long lasting.
Thank you so much. Just in the interest of time, I believe we'll have to move on to the next question. But Linda, I really appreciate your point kind of on the socioeconomic disparities, and we see how that multiple times means that there are groups of people who experience the impacts of COVID disproportionately to others, not just in terms of their physical health and their mental health as well. We'll move on now for a question initially for Devi by Liz, who is an executive MBA student. Thank you.
Thank you. Yes, you've both mentioned about the economy. So I'm just wondering, how can we achieve the optimal balance between powering up the economy, but also keeping people COVID-19 free?
Thanks. Yeah, this has been, I think, the huge question for governments across the world. And I think that what has become clear is that the governments who thought they could save their economies by taking the health hit in a way have been mistaken. If we look at the United States, it has one of the highest caseloads, but their unemployment is massive as well. And they're taking a big GDP hit. We've seen this in Britain, that we unfortunately took the high hit in terms of deaths, but we're also going into, unfortunately, a recession. So I think what's become clear is that you can't oppose health and the economy. They're actually interlinked, because the economy affects health, as Linda said, as well as if you don't have your public health problem solved, your economy is never going to recover. I was reading a report issued by Dell, this group I'm involved with, by two economists, and Nick Stern and Tim Besley, and they were reflecting on this. And I've talked a lot to epidemiologists, but the economists, I think, have been unfairly categorized as being against health, and they're actually not. A lot of the economists are saying exactly what the health people are saying, which is that if you loosen restrictions too quickly and you try to go back and you see the jump in cases, all you're going to do is, worsen the economy. One, because you're not going to have confidence back. People are going to work from home, but also because you might risk having a new set of restrictions coming in. So go slowly and cautiously is the way, and also be more targeted in your restrictions and in your furlough support. And so I guess looking ahead at what does this mean, I think that where we are in the UK is probably where testing and tracing can do a lot of the work if we're cautious around super spreading events, and that actually we should focus on the parts of the economy we can get going. And the parts of the economy I think that are the hardest to figure out are pubs, bars, the nighttime economy. No country, Taiwan has figured it out, but they've eliminated the virus. So they can have their clubs and their parties, but they have no virus. If you have any kind of virus circulating, you get these super spreading events. And I just don't know how you can deal with that. So at least my view is you probably have to figure out how you tailor your economic support to those sectors which are the most risky. So you support those businesses and then get the rest of the economy up on their feet, and then get public confidence that actually it is safe to send your kids to school, and it is safe to go to the coffee shop, and it is safe. Yeah, so that's my take, but I don't know if Linda and Jonathan want to come in on that.
That was excellent. I'll just be very brief. The other thing I would add to that is the groups that we need to protect most through this. So younger adults, the young people who are leaving school now and whose employment activities will be severely constrained. And I think a number of governments have already committed to doing that. So we absolutely need to protect that generation. That's the first thing. And the second thing is, there have been worrying signs that disinvestment in education may be on the cards in some countries just because the economies are so stretched. And that is absolutely the wrong approach. We have to protect, we're not just saying this because we work in the university sector, but it's generally the case. Schools, further education, universities, they are the key to skills and the economy of the future. So those are the two things I would say that we mustn't lose sight of as we come out of this.
Yeah, I agree with what my colleagues have said. I think thinking of it a different way. So we're going to have a tough time now for a while. I'm old enough to have lived through several what now turn out to be quite small recessions. They certainly didn't feel like it at the time. Of those, the one that was in many ways, if something bad can be good, least bad was the 2007 one. The reason it was least bad was because there wasn't particularly a lot of unemployment, which to me, even the word unemployment, you don't have any useful thing to do, is a travesty. It's really undermining of the human condition and our psyche. And this one looks as though it's going to generate quite a lot of unemployment, and that's terrible. And that's something that's very bad for health, and it's very bad for people's well-being, mental, physical, and everything else. But there are new COVID-related opportunities. Online, digital, data-driven opportunities are actually to the fore. So I think we're going to change the world. I think the world will alter. I think we will have all sorts of new industries. There will be new ways of doing things. They will automatically, by their nature, be more green. So we will be protecting our living component of our planet. A colleague very wittily said that the planet doesn't care whether there's global warming or not. It's just a piece of rock floating around in space. But for those of us, all the species who live on this piece of rock, we certainly care about those things. And again, there are opportunities now to do things in different ways, enforced by the pandemic and its long and hard economic and social impacts. So what I'm looking to, and I hope our students are going to be contributing to that, are all the new industries that are going to employ people in different ways for the next 10 to 15 to 20 years. So I see opportunity as well as threat.
Thank you, Jonathan, for sort of ending that question on a slight note of optimism. I think it's always needed. We'll move on to our next question, who's actually from a prospective student. So firstly, welcome to the University of Edinburgh. A very interesting time to be joining us, but I hope you're looking forward to starting your Masters in Medical Anthropology. Gabriel, I'll hand over to you for a question initially to Linda Bauld.
Thank you very much, and hello everyone. And what I would like to find out from you is if you could connect the current situation of the pandemic with how Brexit is likely to be treated by the end of this year, beginning of the next, and what impacts you think is it going to have upon it?
So it's ironic that we're dealing with two such major historic elements of change in the UK. So as you know, the UK left the EU formally on January 31st, the beginning of this year, and we're due to complete the transition at the end of this year or just beyond that. And I think this poses big challenges for the UK. The smaller ones have been that, some of the negotiators have been unwell during the pandemic. We've seen a big disruption to the negotiations, and that has been challenging. But I think the two have to align, and there are big risks associated with that. So just in terms of our economy and our supply chains, the trade deals that have to be sorted out, think about it for goods and services, but includes things like medicines, which are key. There's huge upheaval involved, and we're nowhere near the end of that process. So I think it places the UK, and this is a personal view I emphasize, at a disadvantage in terms of trying to cope with Brexit and COVID-19 at the same time. The other thing I would say is that in order to resolve the agreements that need to be made, the EU 27, so the EU member states, need to act together to negotiate with the UK. And I think COVID has also placed real challenges on their ability to come to a common consensus and find a way forward. So I don't have an answer for you, but and I'm sure Jonathan will have important comments to make on this. I think it is incredibly challenging. But I would emphasize that at each stage in the process, UK institutions, including universities, have been very resilient in dealing with this and trying to continue to welcome particularly our international students as we deal with the challenges of Brexit. Jonathan, I'll hand over to you for any comments.
Must always remember to unmute before I open my mouth. It's a novice's mistake. So first of all, will we have a treatment for COVID before the end of the year? I think we would be a very, very lucky species indeed. There's lots of attempts to make vaccines. There's about 160, 170 vaccines. So first of all, nowadays, to make a vaccine, a candidate vaccine, is a trivial undertaking. It's few days, few weeks work, whatever your strategy. And there are many different strategies being taken. The problem with vaccines are twofold. One, toxicity, usually not the main problem. but they can be toxic and make people ill. And the other one is inefficacy, failure to work, and that's the commonest. And by far the majority of vaccines fail because they're not efficacious. So teams are built, and those are international teams. Now, what could you do to make your international team least powerful if you were trying to build a vaccine or to try and repurpose or build a new drug? After all, the last great major viral pandemic of my lifetime, which is HIV/AIDS, 40 years old, still doesn't have a vaccine. But we've got great treatments. We've got treatments because we understood the biology of HIV and targeted various of its genes or gene products. This is another RNA virus, the SARS-2 virus. It's a bit different. It's got targets that people could go for. So, will we get a treatment? Yeah, we will eventually. Will it be a vaccine? Don't know. Will it be a drug? Could be like HIV. Don't know. It will take time. How do you sort these things out? You build international collaborations. How do you build international collaborations? You have your friends. And is leaving the EU going to make those international collaborations easier? I think you can draw your own conclusions on that, but not immediately, obviously, that it helps us.
Thank you both, Linda and Jonathan, for your answers there. And that leads us quite nicely onto our next question from Cecilia, who is a population health science PhD student. And this question is initially for Jonathan.
Thank you, Helen, and many thanks to the panel. So a few months ago, we saw a controversy around the immunity passport. Some governments, including my country, Chile, suggested the use of immunity passport, i.e. digital or physical documents that certify an individual has been infected and is purportedly immune to SARS-CoV-2. So my question is, what do we know so far about immunity to SARS-CoV-2 and how it is developed? Do we know if we have good ways to measure antibodies, how many people have immunity in different countries, and how long immunity may last? Thank you.
Thank you, Cecilia, and buenos días.
Buenos días.
¿Cómo estás?
Muy bien, gracias.
So I will do my very best to answer this. I would point out that my immunology degree was from 1977, and I'm not an expert immunologist. I'm a hormone specialist, but it's actually quite straightforward in a way. Let me first of all set this into context. So one of my favorite diseases that I've worked on is called diabetes. Lots of people have heard of it. It affects 6-7% of the world population. Nasty problem with how you control sugar. The best description of diabetes was in 150 AD by Aretaeus in Cappadocia, in what is modern-day Turkey, who said that it is a melting down of flesh and bones into urine. It more or less sums up diabetes. And we've worked on it for 2,000 years, and we still don't know all the answers or even all of the best questions. COVID has been around for 8 months. So we've got a lot to learn. And this is very, very early. 2,000 years, still don't know how to work out diabetes, 8 months. So we need to have a certain degree of caution and humility in answering complicated questions. So there is an immune response to this particular coronavirus. There has to be, otherwise every time you got it, it would kill you. And most people recover pretty well. Some people die, some people have a prolonged, but what's a prolonged illness? Diabetes is it can be an illness for 30 or 40 years. This is an illness that lasts at least 8 months. But who knows what will happen at 1 year and 8 months? Will everybody have recovered? Will people, we just don't know. It's really early. So there is an immune response. We know that people make a classical antibody response, firstly IgM, the rather non-specific antibody response at about a week after the onset of the infection, and then IgG, which occurs a few days later, which is a much longer lasting response. And we know that the antibodies persist in the blood for months in the majority of patients. The more severe the infection, the higher the antibodies tend to rise and the longer they last. So that's the antibody side of the immune system. Are they in the laboratory antivirus? Yes, of course. And do they last forever? We don't know. There are some reports that they decline, but they seem to decline no more than they do with most infectious diseases. And that doesn't mean to say individuals have lost immunity. The other half of the immune response, the specific part of the body's response to an infection, is cell-mediated immunity, classically T lymphocytes. And those are around and they respond to the virus, and they may be much more long-lived, and they are responding in the so-called phase 2 clinical trials of vaccines, and there have been a small number of those reported now. They get both antibody and T cell responses. And T cells are often longer lived, and the sorts of responses, T cells, like all of immunology, has balkanized since I was a student, and there are subsets that do this and that and the other. And there seems to be a reshaping of the immune response in COVID away from memory and specific responses into a sort of more toxic cytokine generating, potentially self-harmful response. But recall what I said about the elderly, who get the worst disease and have the weakest immune responses. So maybe the immune responses, whatever they are just helpful. I don't think we know yet. And so the immune system responds, and the early stage trials of the vaccines show that we stimulate the immune response. Is any of this strong enough that if somebody has had an infection, we could give them a passport and say, you'll never get it again, or if you've got antibodies, you're never going to have it again, you might as well go back to work and do what you like. Forget work. You can go to pubs and clubs and be in close proximity to thousands of other people like you. And we just don't know that yet. It's much too soon to tell. Come back and ask me in a year, and I'll have a year and 8 months of data. Well, of course, not a year and 8 months, but a year and 3 months or 4 months of data. It's just too soon to be sure. And we mustn't over-expect on the science, over-expect certainty when it's not possible to generate it. All we can say is, clearly people recover, so their immune systems respond. Clearly they make both antibody and cell-mediated responses. Clearly their immune system changes with time after the infection, and as far as I can see, there is no convincing case of anybody getting it twice yet, but it's early days. Come back in a year. I mean, the other coronaviruses, which are the best guide we have, things like common cold, some of those are coronaviruses, you do catch again, but this may be different, this may be nastier. So we'll wait and see.
Thank you, Jonathan. I fear we might run over slightly, but I just wanted to ask if Devi had any other comments, just an extension of her presentation earlier in today's webinar.
I mean, I think that's a beautiful answer Jonathan gave about the immunity side of things. This is I think the most challenging part, to be able to have those answers. And what I would say is, to take it a step forward, having worked with different governments, is this is what makes scientific advice so difficult right now, because we can map out the scenarios, as he's done, and say, this is what we think. But governments want information to be able to make good decisions, and they just don't have that scientific certainty, and they still need to make a decision. And I think that's just where I think it's a very difficult situation, where I think other issues where we've had a lot of information, you have more scientific certainty, and then it's clear what you need to do. Or here, there is a wide variation. And so you're making decisions under considerable uncertainty, which means sometimes, unfortunately, you make bad decisions, and that just hopefully can be rectified if you get good information in. So I'll stop there.
That's grand. Thank you so much. So yes, just very slightly running over perhaps, but I'd just like to say thank you so much to our panelists, Professor Linda Bauld, Professor Devi Sridhar, and Professor Jonathan Seckl, and also to our students who have asked their questions. We really appreciate this opportunity to collaborate and have these discussions with you as well. So I'll just hand over to Jonathan to finish up today's webinar.
So I'd just like to echo what Ellen has said. I'm extremely grateful to my exceptional academic colleagues for their time and their really carefully thought through answers and presentations to what is, as I said in my last answer, a very rapidly emerging and very challenging set of circumstances. I'm also grateful to our outstanding students who've asked questions, and hope that the audience, first of all, that we answer their questions, and secondly, that the audience has been inspired to think up their own questions. I hope that if this is successful, please let us know by emailing us if you think it is useful. We'll run this as part of an occasional series where we take the university's world-leading experts and give you, the students, the opportunity to grill them. We'll do this once in a while. Otherwise, Ellen and I won't have the energy to do this more than once a month, but maybe once or twice during the coming semester, we'll try and run something similar. Finally, I want to thank the Ushner Institute, which has hosted this really brilliantly, fantastically put together. This technology is not easy, it's not instantly intuitive, and they run this very well. They have some more programs coming up in the next few weeks, and I would encourage you to join into their webinars. And thank you for attending, and I look forward to further events in this series